Hi everyone, welcome to the third COVID webinar organized by the Society of Scientists, Spanish Scientists in South Africa with the Embassy of Spain. Today we are going to have our second session of treatments and vaccines with Dr. Nerea Irigoyen and Prof. Linda-Gail Bekker. And same as last time, we're going to count with a short introduction video from our ambassador, Don Carlos Enrique Fernandez Arias Minuesa, followed by two talks from our speakers around 15 to 20 minutes. And at the end, we'll have all the questions and hopefully a nice discussion. If you have any questions, you can use the Q&A or the chat to post them, and I will present them at the end. And I think that's all from my side. So I'm just going to share my screen so that you can see the introductory video. Can you hear the video? No.
Not yet. It doesn't seem to be moving.
Okay, let's see.
No, we cannot hear it.
Not hearing.
Not hearing. I always have this issue and it never lets me do it from a hand. How do I enable? Well, this webinar is just happening. Why is this thing not coming down? There we go.
It looks like it might still need to load. Does it?
Let's see. Can you hear it now?
Good afternoon and welcome to the second session of the webinar Treatments and Vaccines, organized by the Embassy of Spain and the Society of Spanish Researchers in South Africa. In this second webinar, we count on the interventions of two of the most prestigious specialists of both countries, Dr. Nerea Irigoyen Vergara from Spain and Professor Linda-Gail Bekker from South Africa, to whom I thank very much for accepting our invitation. Dr. Nerea Irigoyen Vergara has a bachelor degree in pharmacy and is doctor in molecular virology. She works at the virology division of the University of Cambridge in the UK, where she does research on the Zika virus. Since April 2020, she has been researching possible treatments against SARS-CoV-2 that can alleviate the health effect of COVID-19. Professor Linda-Gail Bekker is a Deputy Director of the HIV Center at the Institute of Infectious Disease and Molecular Medicine of the University of Cape Town. Furthermore, she is Chief Research Officer of the Desmond Tutu Health Foundation, and she's a physician, scientist, and infectious disease specialist. She has led numerous investigator-driven studies in HIV treatment, prevention, and tuberculosis. Thank you very much.
Okay. So without any further ado, I think I'm just gonna handle it to you, Nerea, and if you have any questions, just let me know. Thanks.
Okay, so thank you very much, Anna, and thank you to the Society of Spanish Researchers in South Africa for the invitation. So let me know if you can see my screen. Can you see it?
Yeah, we can see it.
Okay, so I'm just going to... Oh, just 1 second. Okay, so good afternoon to everyone, and today I will try to give you my thoughts about what has happened last year, because I think that for every one of us, this has been like a massive change, right? Like how 2020 changed everything for all of us. So I would like just to start with what happened and how I have been living this pandemic. And actually for me, that started the 1st of January of 2020. And two things actually happened that day. So the first one is that I submitted a paper on coronaviruses. And the second one is that I saw this tweet about of Nonia Pariente, which is the editor-in-chief on PLOS Biology, in which she was just saying or just referring to a previous tweet of Matthew Freeman, which is a well-known coronavirologist, that said that he heard there was 7 critical cases diagnosed with pneumonia in Wuhan. And I think one of her major concerns was like whether that was SARS-like, and she was actually expecting that to be something related to SARS. And now we can see what has happened later. So how has been the history of this pandemic? So I think, well, if we just make a timeline of what has happened. So since the 8th of December 2019, that was the first recorded case of a pneumonia in Wuhan. Then by the end of that month, it was already 27 cases of pneumonia of unknown cause in China. And then it was quite surprising because 10 days later, the 9th of January, China announced the identification of a novel coronavirus as the causative of this pneumonia outbreak. And not only that, that also released the genetic map. So we knew the coding sequences, and we know all the genetic code for this coronavirus. So this is when we really started to produce all the science that has been related to COVID-19 since then. So the 13th of January was already the first case outside China. And then the 20th of January, it was confirmed the human-to-human transmission, because before that, we thought it was only going to be like an animal-to-human transmission, and it was not going to be like a massive concern for all of us. But that was quite scary, and that was confirmed on the 20th of January. So the 23rd of January was when the Wuhan was locked down. And I think that this is quite funny because at least I was living in from the West, right? Okay, so they only have a bunch of cases and they're locking down millions of people. And it's quite funny because what has happened after that in the whole world, it was like, well, maybe we should have paid more attention to what was happening in China. So then by the end of January in China, the virus was present in most of the provinces. And then the WHO declared a public health emergency alert. 11th of February, the virus was finally named, and it was called SARS-CoV-2 because that was related to the first SARS coronavirus that produced an outbreak in 2003. So we ended up with all the fancy names that people were giving to the virus, like the Chinese coronavirus, or even in the UK, it was some people calling it the snake flu. And also the WHO named the disease as COVID-19 for coronavirus disease 19 in 2019. So then the 11th of March, WHO defined COVID-19 as a pandemic. And so far today, we are going to reach 60 million cases and 1.5 million of deaths. So I presume that you all know about this, like what are the signs and the symptoms of this disease. And you can have a very asymptomatic disease in which you don't really have many symptoms at all, or a mild disease, more like what is called like flu-like symptoms, which you can have some cough, a bit of temperature, and you're feeling like tired and some fatigue. But then at some point you can start to have like dyspnea or acute respiratory distress symptoms that might be led into multi-organ failure, and this is when you can die. So age is a major risk factor. So people over 65 years, they're in a high risk of developing a much more severe disease. But there are other risk factors. So that means like even if you are young, it doesn't really mean that you are not going to have a severe disease, because you might have an underlying condition that you don't know. So for immunocompromised people or people that do have chronic diseases of heart, lung, kidney, liver, blood, or diabetes, that can be a massive risk factor in the sense of developing a severe COVID-19. And also overweight is another risk factor. So how we can tackle the pandemic, because it seems that, well, that we weren't really prepared for this, not in one country or another one. So just basically at global level, we weren't prepared for this. So we can protect ourselves in different levels. The first one will be the individual level. So what we can do with ourselves. So if we follow proper hygiene measures like hand washing and discard handkerchiefs, also to cuff or sneeze into your elbow, and if we use a face covering or a mask in a proper way, so that means just covering your nose and mouth, not in your neck or in your shoulder or in your elbow or anything like that. That doesn't work like that. Also, if we keep some physical or social distancing, I prefer to say physical, because in the end what we need to be is like at least 2 meters away from each other, and not so much social, because we can always go into social media or like different methods like Zoom like now. So it's just basically keep 2 meters away. Try to avoid crowded places. So I mean, if you are planning to go to a restaurant or to a bar and then you see if there are like too many people, even if you are allowed to enter into that place, don't go inside, because that's a major risk. Always try to have a very small number of contacts, and always the same ones. So I like to say that I want to keep between 5 or 6 maximum of people that I do really interact, and always are the same ones. So if the worst come to the worst, so if I become infected, I can always tell them, and it's not going to be super difficult to trace them. And also try to spend as much time as possible outdoors or in very well ventilated spaces. I think this is quite easy for you guys that you are in South Africa, but for us that we're just facing the winter, it's going to be a very important issue that we will need to address. But also not only ourselves, so many things should be done from the institutional level. And the first one is that we should have had a public health emergency preparedness protocol in place. And it seems that we haven't had that for the first wave. Not sure whether we have had this one for the second wave. And I would be very surprised if we do something better, at least in Europe, for the third wave, that probably we're going to face after Christmas. So all the countries should also have a good and increasable diagnostic capacity. So that means something that you can ramp up when the number of cases are increasing. And an appropriate test and trace system, not only a mobile phone app that is going to tell you whether you have been into a close contact with a positive case, but also contact tracers that can call you and can just basically trace all the contacts of a positive care. Also, we should increase the capacity in primary care and hospitals, as well as in intensive care units. I think when all these measures do fail, is when the only thing that you can do is just basically go into regional lockdowns or even home lockdowns. But to be honest, that should be like the last thing that we should be doing. But also how we can tackle the pandemic from the scientific point of view. And this is when we start to have like treatments. Okay, so treatments for a new virus is sometimes a bit too difficult to have in a very short period of time. But I'm going to give like a brief overview of what we have so far and what we can be developing in the very near future or the near future. So the first strategy to fight the virus is with antibodies, okay? And in this case, we can have 2 different strategies. The first one is what is called convalescent plasma. So that means if you have been infected with the virus and then you have recovered from the infection, your plasma can be taken and then put it back into a newly infected person. And then the neutralizing antibodies that you have created might help to clear the virus and prevent infection of new cells in this new patient. So far in some of the clinical trials doesn't really work extremely well. But something similar to this has been the monoclonal antibodies. So that means that we have been able to identify that the best neutralizing antibodies against the virus that has been produced in vitro in the lab, and then they are injected into patients, and then you are preventing the infection. So there has been 2 monoclonal antibodies already approved. And this seems to be working like pretty well. So even Donald Trump was treated with this kind of antibodies cocktails, and seems that worked quite well for him, right? So then the other thing that we can do is just to prevent the infection. So, and actually in that case would be the enter of the virus into the cell. So we need to realize that the virus will enter the cell through a receptor. In this case, will be the ACE2 receptor that also needs a protease, which is the TMPRSS2 here. Okay, so what we can do, so if we want to prevent the entry of the virus into the cell, we can block this receptor. So then what we are just basically causing is like, okay, so the virus won't be able to enter at the receptor, so it won't be able to infect the cell. But if we are unlucky and then the virus has managed to enter the cell, the next thing that the virus needs to do is just to release the genetic material, so it's RNA, into the cytoplasm in order to replicate, so to reproduce the genetic material and also the proteins. So in this case, and this is when all the chloroquine or hydroxychloroquine took place, because there are molecules that are unable to release the genetic material into the cytoplasm. The problem in the clinical trials is that that really didn't work extremely well. So what happens next? Okay, so now we have the genetic material in the cytoplasm, and now the virus needs to replicate, so needs to produce more copies of that. And this is when the typical antivirals is when it took place. So we need to remember that a virus basically hijacks the whole cellular machinery. So if we try to target something to prevent the virus, mostly we will be targeting our own cells. So that can be super toxic for our cells. So a very good strategy is just to tackle or target these proteins that are exclusively viral. So in this sense, we have what is called the polymerase, and this is where the remdesivir, which has been a very famous drug, might have played some role. The thing is, like remdesivir, or at least what the WHO said like last week, it was that not really working extremely well, and it was a very expensive treatment for what you were achieving. There are some other targets like the protease, and some of the drugs that has been repurposed has been HIV drugs. Maybe Linda might know a bit more about this, but I don't think that has really worked extremely well. So we need to make sure that in this case, what we are doing is what we call repurposing of drugs. So it's just basically getting drugs that have been approved for different treatments or viruses and try to check whether they might work with coronaviruses. Because if we want to develop like very new antivirals for these kind of proteins, that's going to take much longer than just only 9 or 10 months. Okay, then here is when so you cannot select there is any kind of treatment in this step, and this is what is called the translation step. So what happens here? So what we do is just to express the proteins of the virus. I would like to tell you a bit more about this, but we are just currently submitting this paper, and we have interesting results in this and some potential treatments that might work. So pay attention in the next few weeks, and maybe we have also good news of this. So what happens next? Okay, so here in this fight, we have the virus that is trying to infect the cell, but we also have the immune system that somehow is trying to protect us. So another strategy that we can follow is trying to boost our immune system, and this is what we use interferon. So what happens with this is just we keep all our cells in a kind of antiviral state, so they cannot be infected any longer. And interferon has worked extremely well with hepatitis C. And also, the problem with our immune system is that at some point, and especially in people which are older or might have underlying conditions, it overreacts with infection. And this is when it can really cause a lot of problems to us. And in that moment is when we need to reduce and lower the amount of our immune system and all the proteins that are releasing, like the interleukin-6, trying to prevent the inflammation that in the end might cause us more harm than good. So there has been a couple of monoclonal antibodies that trying to reduce the interleukin-6, and also dexamethasone, which has been the only drug so far that has been approved, and it might have some, that actually has some impact on COVID-19. So what happens with dexamethasone? It just basically lowers the inflammation, so it just produces less cytokines. So then your immune system won't be overreacting. The only problem with this is like if you can only use this when you have had the infection for a long time. If you do it early in infection, because it lowers your immune system, the only thing you're going to have is probably a much worse infection. So how is the other thing that we can do to tackle a pandemic? So it's just creating vaccines. So the traditional development of the vaccine, as you can see here, can take 15 years or even longer. First, you need to be doing all these preclinical studies with animal models, and then is when you know that that's effective and it's safe, is when you move into clinical trials. So clinical trials might take like years, from 5 to 7 years. And then once the clinical trial has been successful is when you submit all the information and you apply to be approved. And this is when you start to have your large-scale production. What has happened with this pandemic? So basically, we have just basically reduced that to between 10 months and probably a year, or even not even a year and a half. So why has happened this? Okay, so the good thing is that we had a lot of pre-existing knowledge from related coronaviruses such as SARS and MERS. So we knew what we could do to develop a vaccine. And most of the things it was, okay, so let's go to extrapolate what we know into this new virus. Also, the preclinical trials didn't take much longer. And in the clinical trials, what they have done is just shorten all the phases to the minimum time that we can do. And most of them has been overlapped. As you can see here, phase 1 with phase 2, and then when you are in the middle of phase 2 is when you start at phase 3. So the other thing is like some of these big pharmaceutical companies have been producing while they were still on phase 3. So this is a massive risk, and this is why some of them has been asking to the governments to bail out just in case if they fail. It might have some ethical connotations as well. So most of the, or at least since last week, we know that there are some of the vaccines that has had a very good effectiveness that might be submitting to have to be approved in weeks. So most of these vaccines will be approved via emergency. So that means that the time will be reduced quite a lot. So this is a great success because we might have had like quite good vaccines in just a year. So how are all these vaccines? So most, not to say like all of these vaccines are against the spike protein. This is the one that is just outside the virion. And this is the protein that needs to interact with the receptor in order to enter the cell. And most of the neutralizing antibodies are against this protein. So this is why mostly like 95% of all the vaccines are going to be against this S protein. This is a summary of all the vaccines that are actually in the different phases. As you can see, most of them are still in the preclinical phase, but we have some of these in phase 3. Even here says they might have some licensed ones, but that's not really true. Well, there is one, a Chinese, the CanSino vaccine that has been licensed, but only for military use. And there is also the Russian vaccine, Sputnik 5, that basically didn't have any phase 3. So they moved from phase 2 into license. So some of them are already in phase 3, and these are the ones that we had like good results during the last week. In here, what we have are 2 adenovirus-based vaccines. The first one is the University of Oxford AstraZeneca one that are using a chimpanzee adenovirus as a vector to develop the S protein into the cells. And also Sputnik 5, which is the Russian vaccine, which instead of using the adenovirus, they're using a human adenovirus. Also, there are 2 other vaccines, which are RNA-based vaccines, which are the Pfizer one and the Moderna one. And I think that for this vaccine, this has been a great success because I don't think no one was really trusting an RNA vaccine until now. So which are the challenges in order to develop this kind of vaccines? So first, what we need to have is safe and effective and a vaccine that can provide long-lasting immunity. Nowadays, most of the vaccines that have been developed and they are in phase 3 will just only reduce symptoms, apart from maybe the AstraZeneca one, which they might also reduce transmission. So that means that, okay, you can get infected, you won't have a very severe COVID-19, but you need to be aware that you can keep transmitting the virus to the people. So this is why you should be isolated as well. Another thing is also the administration route. So that can be intramuscular or intranasal. So the natural infection occurs in the nose and the mouth. So the intranasal administration will be closely related to the natural one. So will provide better protection in the upper respiratory tract as well as the lungs, whereas the intramuscular one will be just basically in the lungs. So who should be vaccinated first? And this is another issue. So probably what we should do is just to vaccinate healthcare system workers and social carers, and then adults over 65 or people with comorbidities. And then will be the general population will be the ones that will be vaccinated. Also, the vaccine distribution is going to be an issue. As I said, there are 2 mRNA vaccines, which are the Pfizer and the Moderna one, but they all need ultra cold chain. So that means they need to be maintained between -20 and -70, 80 degrees. So that's only that's going to happen in developed countries. And even in developed countries, that's going to be a real issue because there are not so many places where you can keep or storage such a huge amount of vaccines at such a lower temperature. The other thing is what has been called the vaccine nationalism. And what do I mean by that? So this is a bit outdated graph, but can provide what I want to say. So here we have all the bigger pharmaceutical companies that are developing the vaccines. And these are all the countries that have already buying or just kind of dealing with some of the doses from all these big countries. So what we can see here, so it's mostly the United States, the European Union, the UK, Japan, and Brazil are just basically getting all the doses that all these companies are producing. So what happens with the rest of the world? Because, I mean, this is a global problem. So unless we tackle the problem globally, we will still be on the risk of having outbreaks. So what happens with South America or Africa or Southeast Asia? So please pay attention to this, what is called COVAX. So COVAX is a groundbreaking global collaboration that will accelerate the development, production, and equitable access to tests, treatments, and vaccines. And it was created with the idea to guarantee fair and equitable access for every country in the world. And this is co-led by Gavi, which is the Vaccine Alliances, the Coalition for Epidemic Preparedness Innovations, CEPI, and the WHO. Another big problem with all these vaccines is that we have all these anti-vaccination movements, what we call the anti-vaxxers. Also, I just would like to give like a very short talk about what is infodemic and fake news. That has been another massive pandemic, and it has really played a role in what is happening. So how we can describe infodemic? So it's the excessive amount of information about a problem that is typically unreliable, spreads rapidly, and makes solution more difficult to achieve. Basically, it's the spread of fake news. So now I'm going to give you like some of my favorite fake news that we have been living during these last few months. Well, the first one was that the virus was created in a lab, or that the virus escaped from a lab. And that was quite interesting. Well, I presume they're all aware of the Chinese virologists that claim that the coronavirus was made in a lab, and she tried to publish a paper saying how the virus was created. I don't know if any of you have read it. I did it, and it was like, well, if one of my students is trying to give me that as an essay, I would be like, okay, come on, you failed. So, I mean, it has so many problems in terms of molecular biology that it would be quite difficult to believe any of that. The other thing was that SARS-CoV-2 did contain HIV sequences, and this is why it was created in a lab. And it was said by Luc Montagnier that awarded a Nobel Prize by discovering HIV. Which are these HIV sequences that SARS-CoV-2 potentially has? Well, this is what we call the furin targets. So, but that's also a sequence that is also shared by most or a lot of cellular proteins and some other viruses, like highly pathogenic influenza viruses and other coronaviruses, and even dengue virus. So, I mean, this is not a real proof of anything. Some of the other fake news was like the virus doesn't exist. So this is what they call the virus deniers, and doesn't exist because it can be isolated. To be honest, the virus was isolated the 9th of January, and since then it has been isolated millions of times. So, well, this is another fake news. And this is my favorite one, but I mean, probably all the people that come from Spain might have heard about this one. So Miguel Bosé is a famous Spanish singer, and he said in August something that for me is like the merge of all the conspiracy theories, when he said that with the vaccine, they will insert us a chip that will be activated by 5G, and Bill Gates will control us. Come on, that's brilliant, right? If you just want to write a story, like a terror story. So now, just to finish, I would like to share some of my thoughts from the lockdown. And I would like to make you think about what has happened in the last few months. So, for example, what has been the response between scientists, that I think it was like not bad at all. Maybe we could have done things better, but I think that in general has been quite good. We have tried to be collaborating amongst ourselves. We have tried to release our data as soon as possible. So I think has been quite good. So how scientists has response to this compared to politicians versus the economy. And in this point, I don't know, at least from the Eurocentric point of view, some of the politicians have been trying to prioritize the economy, opening up during summer months. And this is why we have the worst second wave in Europe. And probably this was just to try to open the whole thing, trying not to damage the economy. Also, how the East or all the Asian countries have responded compared to the Western countries, such as Europe or the United States. And one of the worst things here is like, well, I don't know what happens in South Africa, but at least in Europe, you see that people are demonstrating because they want to go to the bar, they want to go to the pub. And this is because they think that with all this pandemic, we're just basically just limiting our individual freedom. So maybe we should really think more about the society or about the collectives and not just our own freedom. Also, some of the things that has happened with the last few months has been the nationalism, as we have just seen with all the different vaccines, but also when the states were just basically blaming China for releasing this Chinese coronavirus. I think that the only thing that has happened is just to increase racism and xenophobia, when we should have been globally cooperating, especially because the pandemic is global. So unless we finish with this, all of us, that's going to be a problem for all of us. And also, sometimes how politicians have behaved compared to citizens, or how has been some of the measures that politicians had without really thinking what is happening with the people, like with the normal people, right? And I hope that we can learn a bit more for the next waves that we might have before we can have access to the vaccine. And also, just to really finish, is just to think that we are live in a global risk society that has actually been created by us as humans. The only thing is like we are still accumulating risk. So we have ecological risk that is also there deal with the climate change. We have pandemic risk, financial, social, military, terrorist, biochemical, and misinformation risk, which are all of them interconnected and feed them back. So hopefully we will be over with the pandemic in the next year or the next year and a half. But unless we start to change our mindset, we will be probably facing another pandemic very soon. So thank you very much for listening. I will be very happy to take your questions.
Thanks, Nerea. That was a really interesting talk. I think we can go ahead with Linda-Gail's presentation, because I'm aware she won't be able to stay much longer after 6, and we can leave all the questions for the end. And if you can go ahead, Linda, and share your screen, we can keep moving.
Okay, thank you very much.
Thanks.
I'll try and share my screen. I hope everyone can see that.
Yeah, we can see it.
Great, wonderful. Well, I'll try and be very brief. What I thought I would do, and Nerea, that was an amazing overview of the whole of COVID-19. So well done. That was an extraordinary effort. And I hope this talk will really complement it, because I'm going to be quite parochial and inward looking, and just discuss the COVID-19 research going on at our center, and use that as a sort of a springboard to raise a few issues that I think you have already alluded to, so it should be easy to do. And not wasting any time, I just want to remind everybody that we have a number of health priorities. The two that we pay a lot of attention to is that of the HIV epidemic, and remind everyone that we have the biggest HIV epidemic in the world in terms of numbers of people infected. It is sort of approaching 8 million people living with HIV. We're doing pretty well on our first 90, but we fall off quite severely in terms of the numbers of people on treatment who have been found for treatment, and then even worse in terms of how many people are virally suppressed. And then, of course, TB is a significant problem in this part of the world. And I'll just point out that in Cape Town, where I live, we really are an epicenter. So we notify more tuberculosis from the single metro every year than the whole of the United States, United Kingdom, and much of Europe put together. So just to give you a sense of how big our problem is compared to other parts, to realize that COVID comes to us in the midst of the TB and HIV epidemics. To the north of us, malaria can also be added to that mix, and malaria is very serious. We don't have as much malaria in this country, although there are parts of the country that do also have malaria. So where are we then in terms of COVID? Well, at this moment, we're sitting on about 750,000 cases, 21,000 deaths. That's working out just under a 3% case fatality, which fits in. We have also coming out of the South African Medical Research Council excess deaths, and we don't know what is contributing to those deaths. They were reported by the South African Medical Research Council. We don't know how much of that is unreported COVID or how much is due to the lockdown and other other issues that have happened because of the lockdown. So how much might be unreported TB or HIV or other deaths that were not expected. Now, people have worried a great deal about the collision of TB, HIV, and COVID-19. This is the best data that I've seen. It's come out of Cape Town, out of the public health, and it uses public records, public laboratory records. It was described at AIDS 2020, and you can go and look on site at the abstract. Is now being published by Marianne Davies, so you can also get it at Medrix. I'm not sure if it's officially out yet as a peer-reviewed publication of the impact of TB, HIV, and COVID-19. But I'll give you the bottom line here, that essentially, when you look at the numbers of people who, or what kinds of individuals may be more likely to have a death related to COVID, then diabetes and hypertension, like everywhere in the world, completely outstrips HIV and TB. So you see 12 out of every 100 would be due to HIV, sort of 2 and 4 out of current and previous TB, compared to 52 out of 100 in terms of diabetes. So these other comorbid states seem to have had much more of an impact, pretty much like the rest of the world. So this is our story. We did have a very well-regulated, harsh lockdown in terms of mandatory laws that started way back in March. And the South Africans on the call will know that we are now in a sort of level 1. It is still a state of emergency, but we're down to level 1 with a much more lightening of regulations during this time. But at the time of the severe lockdown, we had, a series of things that happened. For example, a single COVID message that was delivered from the top down. The president came on the telly quite often. The health minister was in the social media almost on a daily basis. The need to stay at home was mandatory. There were no services other than the essential. People were really encouraged not to go to work. And clinics really were seen only as a place for COVID management. There was a fear of forced isolation. People would be removed from their homes, pushing COVID underground to a certain extent and leading to stigmatization of the disease. And then for other people dealing with other problems such as HIV and TB, there was really quite a lot of ambiguous messaging, ambiguity about how long this would go on for, ambiguity about whether people could travel at all, and of course fear of reprisals, with quite a staunch lockdown both from the army and from the police. Now, this results in some direct impacts, and the direct impacts on health in general was related to the single focus on one single disease. All other kinds of health screening stopped. Other treatment initiations such as antiretrovirals and TBs were delayed or pushed later. Antiretroviral pickups were delayed, with treatment and pre-exposure prophylaxis interruptions or treatment sparing. Of course, contraception would also be interrupted. There was a fear amongst people dealing with health-related issues of contagion and not wanting to come to clinics. We've battled stockouts, lack of support for people with chronic problems, social support lack, the stopping of all research for a period of time, including key and critical TB and HIV research, and of course, health facilities closing with quite a lot of hostility around those facilities that remained open, with closure of other services. The lockdown itself also had an economic impact, so loss of income, food insecurity, associated depression and anxiety, the ignoring of other problems, ignoring of other health priorities, including, for example, the essential immunization schedule, fear of attending clinics, gender-based violence we've heard a lot about, family violence, associated crime, civil unrest, corruption that's going on at the highest levels, lack of income, and of course, general poverty. I worry a lot about the cascade, both for TB and HIV, and I merely show this to remind people that there is a cascade all the way from health-seeking behavior through to viral suppression if we talk about HIV. Of course, it's cure if we talk about tuberculosis. And I do think the lockdown has had an impact everywhere along the way in terms of being able to manage and maintain that important cascade. There has been some modeling work to show the impact of lockdowns around the world, and this has come out of the WHO, John Stover and others, that it's estimated we will see huge regression in our progress around, for example, mother-to-child transmission prevention, efforts to overcome interruptions in health services and supplies, could lead to more than 500,000 extra deaths from this one particular modeling study, and really contributing to excess deaths. We know what has happened, that was a modeling study. What we've heard on the ground is that up to 73 countries experienced some level of stockout, 24 countries having critically low levels of antiretrovirals, and we know we're still trying to catch up there. 36 countries, which comprise 45% of the global number of people receiving antiretrovirals, reported some kind of disruption. So people not picking up their antiretrovirals. In South Africa, we can report that we saw up to a half the number of TB screens done during this time, with a third fewer antiretroviral pickups. So I think really important to recognize that. And this is just a bit of data out of the United States of America, showing how immunization amongst children, childhood immunization, fell off during this period of their initial surge. And I haven't seen the most recent data of their secondary surges now. So we know that this is what can happen. We've spent some time thinking, well, what else can we do? Well, what could we do differently? And I think if this happened again, I think it is useful. We've somehow left community advocates out of this process, that we should really activate them a lot sooner, make sure that messaging at ground level is clear. It should be unambiguous and more nuanced. In other words, COVID is not the only problem here, but there are other health matters that need to be dealt with. And also we need to think how to mitigate the kinds of harm that a single focus can do. So for example, differentiated service delivery, which takes into consideration a more integrated approach. It talks about telemedicine, about multi-month dispensing, about pill pickups, courier treatments, other ways to get treatment to people to make sure that they don't fall between the cracks. These are some of the measures we took at our organization. We became very aware that COVID could have a real impact on TB and HIV very early on in the lockdown. And we immediately started to advocate that services could continue, that TB and HIV would be seen as essential. And we were able to do that. We made all our systems COVID ready as quickly as possible. That included some infrastructural differences. We drew COVID into our services rather than having COVID as a single entity, but really to bring COVID into other integrated services, making our services COVID protected, amended our protocols where needed, and obviously also contributed to COVID research. And so you see some of the things we've done. We've created these screens. We've got a whole lot more things in to make people feel like they could be safe even though they came to our facilities. And I'm pleased to say today all of our usual HIV and TB services and research are fully back on the road. In the next few minutes, I'm going to talk about what we are doing that is specifically COVID related to try and understand how we can improve the response in the future. So this we're calling the BUDDY study, bidirectional upbeat communication and differentiated distance care for young people. And here we're effectively looking at the acceptability, feasibility, and effectiveness of a remote service delivery model. In other words, an Uber service to get antiretrovirals to adolescents living with HIV. We're looking at the impact of lockdown orders on gender-based violence and other family-related violence. And then we are randomizing these young people to either receive a bidirectional telemedicine support structure as opposed to just allowing the pickup. So to see what mental support we can give these young people who would normally rely on clinic contact to maintain it. And so here you see our design. These young people are being randomized to messages or not messages. They can choose whether they have their treatment delivered to them by Uber. And we're comparing that to a bunch of kids not living with HIV to see what the impact of the lockdown has been for them. And we hopefully will also be monitoring how much COVID these young people develop as a result of the impact. The Crown Coronation study is an interesting one. It is looking at, and I'll move quickly because I think Nerea covered this very nicely, that not everybody gets disease, but obviously it's very important amongst healthcare workers that we try to keep them as free of disease as possible to keep them in the workforce. So let me back up before I get there. We do know that the ways we can diagnose COVID is to measure the virus itself, as she mentioned, to measure the antigen or to measure the antibody. And we know also that viral burden decreases after initial onset. The PCR can remain positive for quite a long time, although viral load itself decreases. And then we can use something like an antigen to detect whether somebody has actually got an infection. And finally, we can measure antibodies. So that's the human host response. As the viral load decreases, usually the antibody increases. And this is the typical sort of picture we see in mild disease versus more severe disease. There are still some unknowns we need to think about. Can people become reinfected? And we are certainly beginning to see some case reports around the world. Are antibodies a correlate of immunity? If so, what quality of antibody is important? Does it need to be neutralizing? Is there a threshold of protection, and how long will those antibodies last? What we do know is that certainly COVID patients do mount an IgG and an IgM. COVID patients mount neutralizing antibodies as well, and the magnitude of the antibody response seems to correlate to disease severity. So as Nerea asked, where can we intervene? We can obviously avoid exposure. We can come in with a vaccine. We can come in with pre-exposure prophylaxis, and we can treat the early phase, or we can treat the later phase of the disease. The non-pharmaceutical intervention she's already covered, and I think they are, sort of similar, analogous ideas in HIV that we can also think about for COVID, and that helps me think about safer behaviors rather than safe behaviors. So she's already mentioned we can think about the 3 C's: close spaces, crowded spaces, and close encounters, making sure that we avoid all of those in order to reduce our risk. So avoid exposure. I am now going to move into our study. Sorry that I got confused earlier by that early study, but this is the first one that is epidemiological. We are thinking about transmission of COVID in crowded environments called TRACE. This is funded by the EDCTP. We're doing this in Cape Town in crowded township environments. And our main question here is to ask, what is the transmission pattern and timing of infection in households from these very crowded environments where the usual non-pharmaceutical interventions are quite hard to do? What is the burden of symptomatic versus asymptomatic disease? And can an intensified infection mitigation intervention reduce transmission? So we're calling that intervention Stop COVID. Households are randomized. A household that is randomized to the intervention, a field worker visits, brings a pack of NPI type interventions such as gloves, sanitizers, masks, etc. And they also bring a whole lot of information. In addition, they have other interventions such as food, referral to social workers, and support to the household. And we're looking at that intervention versus just following up the household over a first 1 month period and then coming back in 6 months' time. And we're measuring antibodies weekly as well as T cells weekly to understand what's happening in those households. So that is ongoing, and we hope we'll have some good data there very soon. The next is exploring natural immunity, and we have 2 protocols looking at this: a prospective study of acute immune responses to SARS-CoV-2, and really trying to understand what happens in the acute first few days to weeks, and this is observational. It's designed to capture the immunological, virological, and clinical data and understand what the viral and immune factors are associated with good and less good outcomes. So here you see we're looking at asymptomatic, symptomatic, and symptomatic hospitalized individuals to understand what might be happening in those situations. In the interest of time, I'll move to this one, which is characterizing COVID-specific immunity in convalescent individuals. So again, observational. These are people who've known to have COVID disease. We're following them up with similar kinds of bloods to understand the trajectory of disease after infection. On the prevention side, we obviously are very interested in vaccines. And Nerea has already described very beautifully that there are a great number of vaccine candidates. The one that we are honing in on involves viral vector vaccines. At our sites, we have 5 sites that are undertaking the Johnson & Johnson Ensemble study. It's a phase 3 of the AD26. Now, AD26 is their viral vector platform, and they do also have this for Ebola, for Zika, and for HIV. We're also conducting the HIV vaccine trial. It's also in phase 3. But we've given our marching orders to enroll up to 30,000 individuals in South Africa. As I say, Desmond Tutu has 5 of these sites. We're currently in accrual. We're expected to enroll 4,000, and when I last looked, about 27,000 people are enrolled into this trial. They too have gone for the spike protein, as Nerea mentioned, as everybody else has done. And the good news is that this does seem to be very antigenic, judging by Moderna, Pfizer, and the AstraZeneca trials to date. Early preclinical animal studies show that indeed they are seeing good immune responses with this vaccine, and so we have a lot of hope for it. We are also part of the Solidarity trial. Nerea spoke about the very important concept of access. This is a large trial that is hopefully getting underway, designed by the WHO, and is designed to try and reach as many countries as possible with a sort of vaccine platform, adding new regimens as they become available. This is an interesting one I wanted to make you aware of. This is the CROWN study. So this is a multi-site, multi-country study, which is repurposing a vaccine. And here we are testing whether the measles, mumps, rubella vaccine can be used to stimulate this trained immunity. And here we're targeting healthcare workers because it's very important that we protect healthcare workers. And so early on, we came in with the measles, mumps, rubella prior to specific vaccines as an option to see if this indeed will make a difference. And we know that there's epidemiological data to show that this strategy of trained immunity can reduce the onset and the severity of other diseases. And this has been described with BCG, with measles, and with the oral polio vaccines. So you can see you come in with this non-specific vaccine, which if you become infected with SARS-CoV-2, your innate immunity is geared up and gets you going in order to protect yourself better against SARS-CoV-2. There's an added hypothesis here that, of course, there are similarities between the measles fusion and the SARS-CoV-2 envelope glycoproteins, and so there may also be some cross-reactivity there. We're going to have to see whether this holds water. It is a randomized controlled trial, and we are in the midst of accrual at this moment. We are doing other things. We have set up a platform to investigate early other possible candidates, and here you see this agile platform is looking for other agents for the treatment of COVID-19, and we are waiting for these various agents. So that was a whistle-stop tour, but I hope it just stimulates some thought around what we can be doing. I think Nerea is absolutely right. The most extraordinary thing about all of this has been the speed with which we've been able to get going. But I'm hoping you will also think about the risk-benefit ratio for hard lockdowns in countries such as South Africa, the benefit and the risk. Community-led responses such as shielding or partial lockdowns might be an alternative in a country such as South Africa, a continent such as Africa. It's always important to think about our health systems and maybe to shore up better, stronger ways to make sure that other services don't stop in the setting of a new epidemic or pandemic, so that when a new priority arises, we think about how we message, how we operationalize, and how we monitor. And then also to think, of course, about the unintended consequences outside of health, such as economic and social consequences, such as violence. And of course, it may need, as we have seen in the last 6 months, incredible innovation and boldness, which I think we have really seen buckets of in recent months. So I'll stop there and see if there are any questions. Otherwise, I'm happy to take any questions for a few minutes.
Thanks, Linda. That was actually a really interesting talk and quite encouraging to see that South Africa is involved in so many different projects. So I have a couple of questions myself, but I'm going to start with the questions that we have from our attendees. So there's this one question in the Q&A from Ntombele, is asking, thank you, very informative presentation. Her question is why we cannot start to vaccine at the places where TB, HIV, and COVID-19 infections collide, for example, in Philippines. Thank you.
I'm happy to try and tackle that one. You know, I think Nerea sort of gave a really important recognition that the next big question is how we distribute these vaccines and where they get distributed to. And I think your question alludes to a very important concept that when you need to vaccinate on such a global level, you are going to have to be very innovative in your distributions. You're going to have to go probably beyond facilities and into other places where high-risk individuals exist. And certainly what we've learned, and what I hope to say, and I know I went over that data very quickly, what we've learned is that our highest risk individuals are the elderly and those people with comorbid conditions such as diabetes and hypertension, actually less so for the TB and the HIV. So I think those individuals will be in the queue, but probably not first in the queue as it happens, because we're going to want to move in to the elderly and those with, and I think that's the truth around the world, and healthcare workers and essential workers. I think we're going to want to protect those individuals first. Nerea, I don't know if you would agree with that.
Yeah, I do really agree with you, Linda. So I think one of the problems is with the vaccines that seems to be much more promising is like, if you really need to keep the cold chain, that's going to be a real problem. But I mean, not for developing countries, even for developed countries, because there are not going to be so many places where you can store these kind of vaccines. So unless we are going to be much more innovative, that's going to be like a real problem. I think the good news with AstraZeneca, even if they do have less efficacy somehow, which seems not to be so real, is like, well, they can be kept in a normal fridge. So that's going to be much more useful for the whole world.
And that's why we also have a lot of hope for the J&J one. It's a single dose, which immediately makes deployment easier, and also it's a room temperature vaccine. So for all of those reasons, again, deployment becomes much easier. So I think we have a lot of hope for the J&J product, given that it's already been successful for Zika and for Ebola.
Okay. Alvaro's question is also regarding vaccines. He says the question is for Linda, but maybe Nerea can also answer. How feasible do you think the vaccination would be in South Africa? Would the government and or insurance companies be able to purchase enough vaccine doses for the whole population without resorting to NGOs, UN, etc.? And if so, are there any predictions about the designated groups to be vaccinated first, according to the government's experts committee advice, if there's any yet?
Yeah, so they're like the MAC, Alvaro, the minister's advisory group that has been advising about the epidemiological response. There is also a specific vaccine group. I know that it's being chaired by people like Greg Hussey, people who've been vaccinologists for a really long time. I think you're absolutely right, cost is king. So we're going to have to see what the prices of these vaccines are when they arrive. And we've been in this space before, as you'll remember. You may or may not know that antiretrovirals didn't come to us for a really long time because they were just exorbitantly priced. And so the North benefited from antiretrovirals and the South didn't get them. And that is the truth with a number of different drugs, monoclonals notwithstanding. So, we are keeping our eye on that price. The good news again is Johnson & Johnson has already, I believe, negotiated an agreement with Aspen, who is our local in-country generic, one of our generic companies. So I'm hearing that there's already movement to try and do a tech transfer as soon as possible, and therefore, hopefully, that'll have an impact on drug pricing. But I think, like everywhere in the world, we're going to have a staged approach. I mean, I can't imagine us being able to get to 53 million people, immediately. So I think it's going to be similar to what you've heard you know, the states, the WHO and others come up with. I think we are also watching what COVAX is doing, and we're hoping, we're not a Gavi country, but I think we are also locked in there. And of course, our president, Cyril Ramaphosa, is quite involved in this at the AU level. So I think hopefully we're going into this with eyes wide open, and we're going to be able to manage this better than most. But I agree with Nerea, probably the biggest worry will be if this thing needs that amount of refrigeration. It's just logistically a huge nightmare. So I'm hoping second generation, third generation vaccines are going to be more amenable to deployment for countries like and places like Africa.
Sorry, thanks. Nerea, do you have any comments?
No, I think that Linda answered it like beautifully.
Okay. So we have another question in the Q&A. Pachi Cervantes says, thanks for an interesting talk. Some countries seem to be doing better than others in terms of infections. Have we learned anything from the different approaches or population characteristics that may help in developing any treatments?
Well, I don't know if we have learned anything from how Europe has responded. I do agree that the first wave like suddenly appeared like in Italy and Spain, and we didn't have much time to do anything, right? So we tried to cope as we could. For the second wave, I think that we have learned is like, well, we cannot ease the lockdowns as we have done already, so that has to be like in a much more controlled way. We have learned a lot about treatments during all these months, so we can cope with infections much better as we used to do back in March. But I think that apart from the like very specific countries as New Zealand that really deal with the pandemic quite well, or the Asian countries, I don't think that we have done a very good job. I'm not sure about what is happening in Africa, but at least in Europe, I think that we have all been doing the same mistakes all and over again. So hopefully we may be able to learn something for probably the next wave that will come just basically after Christmas, because we are having all these lockdowns now. And most of all Europe is going to open up again for Christmas. So I presume that in January we'll have a massive third wave as well.
Yeah, I mean, I would say there's still quite a lot to learn. You know, I think we haven't fully understood what, you know, how much background immunity there is, what the impact of younger, you know, people are. There's some intriguing data around vitamin D, epidemiological data. So I think there's still quite a lot we don't understand about the actual infection. I mean, I think we've learned an extraordinary amount in 8 months, but I think we continue to learn and understand. I personally haven't fully understood why, you know, the patterns have gone the way they have. And I think in the meantime, we have to continue to think, what are the mitigation measures we can do whilst balancing some really important things such as economic factors, social factors, and so on. So, you know, South Africa now is in this stage where the president has asked us each to take personal, you know, autonomous accountability and pay attention to our own scenarios rather than having an imposed lockdown. But that's a lot to ask. And coming out of HIV, I know how people struggle to change their behaviors. So it's, you know, it's for me, I'm very humble about this. I think we still have a great deal to learn.
Okay. I know that Linda needs to leave like in 2 minutes. So I'm just gonna ask a really quick question for you, Linda. What do you think happened? Because at the beginning of this pandemic around March, we were having predictions that South Africa was going to have around 90,000 deaths by the end of the year. And if you see our data, we only around 20,000. So how can you explain this big difference in the predictions and reality?
So I think the one thing I have learned is models often fail because I think our, the modeling studies have repeatedly let us down. And in some ways they've created, maybe it was a good thing, maybe it was a bad thing, but a lot of panic. I think some of the assumptions in those models were just frankly wrong. And models are only as good as their assumptions, right? And I guess when they predict correctly, then we all think they're brilliant models, and when they don't, then they're rubbish models, and that's how it goes. So I think, it was based on one or two that came, and then everybody went down the same road. There've been a few groups that have stood aside, and they've been demonized, depending on which camp you're in. So I think it's been quite interesting to see how the modeling piece has gone. I'll use your wonderful platform just to advertise that we're planning, there's a fantastic HIV conference every year, and this year it should have been in Cape Town. It's not. It's called Research for Prevention Conference. It's a prevention for HIV, but what we've linked to it this year, and it's been postponed, it's virtual. It'll be in January and February of next year. We've linked a single day that is COVID-19 prevention. And one of the talks that we haven't yet advertised all the talks, but I'm giving you a heads up. One of the talks we have is just how useful the modeling predictions have been. Have they been more harm than good? And I think it's a discussion to have. So I think what we had on our watch was just a poor model that failed, that was wrong. Yeah.
Well, I think that probably the assumption that went wrong is that we all thought that TB and HIV co-infected patients were going to do really badly with COVID, and it looks like we are not seeing that. And I think we are thankful for that surprising result. Okay.
Yep.
And a really quick one for Nerea. I saw that you said that these vaccines are going to still make people get infected and transmit. And I know the anti-vaxxers community, it's increasing worldwide. So given this comment, what do you think would make them believe that we should actually go for the vaccines everywhere if we are still going to have the infection and it's still transmitted?
Well, the thing is that, okay, so you can well, the thing is that there are not enough studies, because the only one that has actually been able to bring out some data is the AstraZeneca one, in which they were also testing for swabs after get vaccinated. So they have somehow said that, well, it seems that people are not transmitting the virus so much. For the other ones, we don't have that data. But in principle, we still need to assume that if you don't have that data, that you might be able to keep transmitting the virus. The thing is like probably because you are going to produce less virus as you were producing without any type of vaccination, probably the transmittability is going to be much lower. So that shouldn't really be like a massive problem. But I think that sometimes it's in terms of communication, and we should be like super careful how do we say things, because this is maybe something that should be known in the scientific field, like, well, we are just only mitigating the symptoms, but that's something that you shouldn't say in public, like, oh, you still be infected. So then people would say, oh no, then I don't want to have this vaccine. I think it's one of the problems with all this massive information that we have, is like we are happy living in all these things that, oh, this one provides like 94% protection, this one 95%, this one, come on, we were just basically expecting who's going to be the next one, giving a higher efficacy, right? And then it's AstraZeneca and probably all these adenovirus-based vaccines that would be more like 70-80%. That was what it was actually expected. And then people would say like, oh, I don't want to have this one because it's not a good one. And it's like, well, doesn't really matter. It's like the one that probably is going to be the most available one for this type of vaccines for all of us. So we'll have to take this one. So I think we should be very careful with all these kind of things.
Okay, thanks. So maybe the best way of wording it would be that we should tackle the vaccination as another approach to be able to control this pandemic, but not the only one, and just to keep adding as many possible pieces to this puzzle to be able to control it and sort of go back to normal. Okay, well, this was a wonderful talk. Thank you so much to both of our speakers for such wonderful presentations. We are recording this, so we will upload it in our YouTube channel, and I'll share it in the social media and send it to both of you in case you want to share it with your contacts. And I think we can just wrap it up today. Thank you to the attendees, our 5 super attendees that joined us, and thanks to the speakers. Have a good evening. Bye.
Thank you.